So it's a real pleasure to be able to speak at this conference. It's such an important meeting. And even though the Cubs did not win this year, it's still nice to be back in Chicago. I grew up in Chicago, so even though I'm in California now, it's always nice to come back, although I like it when it's a little bit warmer. But the air is much better here than in California. The fires are really, really bad. Okay, so I'm going to be talking about fresh versus frozen embryo transfer. And, okay, let me see. So my only disclosure is that Somatics has sponsored some of the research, and a couple of the studies that I'll discuss were done in conjunction with their data set. So first I'm going to go over some definitions, then just general fresh versus frozen embryo transfer, fresh versus freeze-only transfer. If Dr. Koudafaris is here, is he here? Yes. Oh, okay. So he is responsible. Are you happy about this? He's responsible for this terminology. He feels very strongly that it should be freeze only rather than some of the other terms that people use. And then I'll talk a little bit about cryopreservation in cancer patients. We don't have as much outcome data in that patient population. Okay, so that we're all on the same page. A fresh transfer means that embryos are being transferred during the same cycle that ovarian stimulation is being performed. Frozen embryo transfer cycles are where embryos are transferred in a subsequent, either natural or medicated cycle after being frozen following an ovarian stimulation cycle. And then freeze-only transfer, which is a subset, are cycles where all the embryos are electively frozen. So going into the cycle, the plan is to freeze everything, and then they're transferred in a later cycle. There are a lot of different terms that are used for this. So some people use elective frozen embryo transfer, freeze-all, which is very commonly used. Actually was the title of one of the papers that we were initially going to use until we were convinced that that was not the correct way to term it. And then people sometimes will use some other terms when they're talking about this. So frozen embryo transfers may include cycles where the best embryos were transferred in the fresh cycle, and so the ones that sometimes are left are the ones that were thought not to be the best embryos. So that's why freeze-only transfers are a better comparison with fresh transfers. So the rate of frozen embryo transfers is increasing very rapidly in the United States. And you can see there's this very nice article that Dr. Shapiro wrote. And from 2006 to 2012, there was an 82.5% increase in frozen embryo transfers compared to 3.1% for fresh cycles. And the most recent CDC data from 2015 reports about 91,000 fresh cycles and almost 70,000 frozen cycles in non-donor cycles. So they're actually, I think in the next couple of years, probably going to be very close to the same numbers. So there are a number of reasons for this increase. The methods for freezing the embryos have become much better, so vitrification actually results in very good survival of the embryos. There's much more use of preimplantation genetic screening, and there is a lot more experience and awareness of doing these freeze-only protocols. So there are a number of differences that have been observed between fresh and frozen embryo transfers in terms of maternal and fetal risks. So it's been reported that reduced risks in frozen embryo transfer, the most significant is ovarian hyperstimulation syndrome. And often in the past, even if patients had planned to do a fresh cycle, if they were responding overly well, sometimes it would be decided to freeze to prevent the risk of ovarian hyperstimulation syndrome. Low birth weight and small for gestational age, preterm delivery, placenta previa, placental abruption, antepartum hemorrhage, and perinatal mortality have been reported to be reduced in frozen embryo transfer. But some things that have been reported to be increased are placenta accreta, macrosomia enlarged for gestational age, and cesarean section delivery, probably related to those factors. And then some of these risks are not that clear. There have been some reports showing, significant differences in implantation, ectopic pregnancy, preeclampsia, very low birth rate, and very preterm delivery, and intensive care admission for the neonates and congenital abnormalities. But those are still, I think, still need a lot more studies to clarify these differences. So the very first meta-analysis looked at 3 studies and found that there was a significant increase in the ongoing pregnancy rate and clinical pregnancy rate in the frozen transfers compared to fresh transfers. And the fresh group also showed a higher miscarriage rate, but this difference did not reach statistical significance. So these were the 3 studies. One of the studies, the first one was doing transfers with day 2 embryos, and then the 2 by Dr. Shapiro and his group looked at blastocyst, and one was in normal responders and in high responders. But you can see 2 of the 3 studies were in high responders. And so in this meta-analysis, they showed that the implantation, clinical, and ongoing pregnancy rates may be improved by performing frozen embryo transfer. And they concluded that this was probably because of improved embryo endometrium synchrony. So controlled ovarian stimulation may have a negative impact on the endometrium. So looking at fresh or freeze-only versus fresh transfer, there's not as much data looking at these. Initially, there were those 2 randomized controlled trials that I showed you, and then some small trials and retrospective matched cohort studies, and they all suggested that there were improved pregnancy outcomes with freeze-only transfer. And then there was one randomized control trial of patients who had euploid embryos and showed increased pregnancy and live birth rates in that group too. So there have been few studies investigating frozen transfer of PGS screened embryos and have not compared fresh versus frozen freeze-only directly. So there are 2 studies that I'll discuss where we looked retrospectively at both non-PGS and PGS screened embryos. And these previous studies, as I mentioned, suggested that frozen transfer may be associated with better pregnancy outcomes because of the supraphysiologic hormone levels in controlled ovarian stimulation that affect genes that are involved in implantation, placentation, endometrial angiogenesis, and endometrial maturation. So there are a lot of changes that are seen in the endometrium with ovarian stimulation. So this was the first study looking at blastocyst transfer and in normal responders. A small study looking at a little over 100 patients, and these were patients who were not in the group that had a very high response, and their pregnancy rate was significantly higher in the freeze-only. So you can see they showed an 84% pregnancy rate in that group compared to about 55% in the fresh group. And also the implantation rates were significantly higher. And so they, concluded that this was due to better endometrial receptivity in the frozen transfers. They also found similar results looking at their high responders, showing that it was a significantly higher pregnancy rate in the patients who had a high number of eggs. Then there was this study looking at fresh versus frozen in PCOS patients, and a large study looking at over 1,500 patients. And the freeze-only patients had a higher frequency of live birth compared to the fresh embryo transfer. Also showed a lower frequency of pregnancy loss and, as you would expect, of ovarian hyperstimulation syndrome. However, they did show an increased frequency of preeclampsia. So you can see it actually increased, it was increased significantly from 1.4% to 4.4%. But they did not see any other significant differences in the groups in terms of other complications. And then there was a very large analysis from the SART data set looking at almost 83,000 patients who had either their first fresh transfer or their first frozen embryo transfer. And they showed that in the high responders, there was a significant improvement in patients who had a frozen embryo transfer. So the frozen embryo transfers had a live birth rate of 52% versus 48.9%. However, in the intermediate responders, they did not see any significant difference. And in the low responders, there was actually a much better pregnancy rate in the fresh versus frozen transfers. So their conclusion was that the freeze-all strategy is beneficial in the high responders, but not in the intermediate or low responders. So, does not show, as some studies have, that freeze-all is preferable for all patients. Then there's been one study looking at euploid transfer, comparing fresh versus frozen, and they found that the implantation rate showed some improvement in the frozen group, but was not a significant difference. But their ongoing and live birth rates were significantly higher in the frozen group compared to the fresh group. So we decided to look at this very large data set that involved 13 academic and private centers across the U.S. And for the fresh cycles, luteal support was initiated after retrieval, and embryos were transferred at the blastocyst stage. And then for the freeze-only cycles, embryos were cryopreserved according to the protocols at each clinic, and then they underwent a frozen embryo transfer in either a natural or medicated cycle, so whatever the clinic typically used. And the cohorts were matched for patient characteristics, so maternal age. We looked at the clinic and gravity parity, diagnosis, body mass index, looked at ovarian reserve, and then looked at cycle characteristics like progesterone, eggs retrieved, the embryo cohort size, and embryos transferred. And you can see the baseline characteristics were very similar after matching. So they overall, were good responders, had around 21 eggs retrieved, and you can see the number of embryos transferred averaged 1.5. The diagnosis was similar between the groups, and you can see a range of patients. And then the pregnancy outcomes, looking at the group overall, we found that the ongoing pregnancy rate was better in the freeze-only and also the implantation rate. But then when we separated out looking at progesterone level at the time of trigger, we found that the freeze-only was only beneficial when the progesterone level was greater than 1 at trigger. And then we looked to see if maternal age factored into this, and we showed that there was a trend toward increasing benefit of freeze-only cycles with advancing age. Then we also looked at the data from this large cohort, and this was preliminary data that was presented last year at ASRM. So again, looking at a large number of blastocyst transfers, so over 1,600, And for the fresh cycles, again, luteal support was initiated after retrieval, and embryos were transferred at the blastocyst stage. For freeze-only cycles, embryos were cryopreserved according to their protocols, and again, each clinic did their frozen embryo transfers using their own protocols. Again, the baseline characteristics were comparable. The only difference was that ICSI was a little bit higher in the freeze-only group, but you can see almost, 95 and 97% of the clinics used ICSI for fertilization. And the gonadotropin dose was a little bit higher in the freeze-only group. The ongoing pregnancy rate in the freeze-only and the implantation rates were significantly higher compared to the fresh, and actually I guess it should be freeze-all. So 53% ongoing pregnancy rate compared to 42.6% with the fresh, and the implantation rate in the freeze-all was 50.8% and 42.7% for the fresh. A pretty significant difference between those. And then we looked to see if in these euploid embryos, if there was a difference with progesterone level. So we looked at age less than 36 and over 36, and with progesterone less than 1 and greater than 1. And so in this group, we did not see any difference in pregnancy rate depending on the age or the progesterone level. So this was a little bit different than what we saw with the unscreened embryos. And again, we saw that there may be a little bit of a trend to more benefit with higher progesterone levels, but it wasn't significant. So our final conclusion from this was that there were higher pregnancy and implantation rates with frozen versus fresh transfer in these euploid embryos, and the progesterone level overall did not seem to factor in. So there were a lot of strengths of these studies because it was a very large sample size. It was a multi-center data set, and we had a lot of detailed information on things that could be confounders. And we were able to stratify by maternal age and progesterone at trigger. And because it was a wide range of patients, hopefully it can be generalizable to multiple patient groups. But it was retrospective, did involve a lot of different clinics, different assays, and there were also different clinics that were doing companies that were doing the PGS. And also we did not have data on live birth and perinatal outcomes. So we don't have a lot of data on outcomes in cancer patients specifically. This was a study looking at 17 years in this clinic. So from 1997 to 2014, they had 63 cancer patients. 6 of them froze eggs, but 57 of them cryopreserved embryos. None of their patients who froze oocytes came back to use them, but 21 or 36.8% returned for a frozen embryo transfer. And then they compared these to age-matched controls who were who had done a fresh cycle in that same time period. And they found that there was no difference in terms of the gonadotropin dose used, number of oocytes retrieved, and the number of 2PN embryos obtained. The cumulative pregnancy rates were comparable between the two groups. However, they did notice, so even though they had a similar number of embryos transferred, the cancer patients had a higher likelihood of live birth resulting in twins. And I think this speaks to it's always important to discuss numbers of embryos to transfer, but especially in this patient population, I think we really need to consider doing single embryo transfer as much as possible in this patient population. There also have been other studies looking at outcomes of egg freezing. We don't have as much data, but Dr. Cobo recently published looking at outcomes in their cancer patients compared to the women who were freezing for non-medical reasons. And in their patient population, 7% of the cancer patients had come back to use their frozen eggs. And in that cohort, they did notice, or they do report that their pregnancy rates did seem lower in the cancer patients compared to the non-cancer patients. So clearly, we need a lot more studies to look at this. But a lot of patients, have not come back to use them, which does make these studies more difficult. Okay, so this study just came out a week ago. So this is a meta-analysis now of 11 randomized controlled trials, so over 5,000 patients. And they did show, consistent with some of the other studies that we've discussed, that there was a significant increase in live birth rate in the hyper-responders compared to the ones who were doing fresh transfer. They did not find any difference in the patients who had a normal response. They did note an increase in preeclampsia, which has been reported before, but they did not notice any difference in ectopic pregnancy, miscarriage, preterm birth, congenital anomalies, or mean birth weight. Now, these studies there's a lot of heterogeneity in the studies, so they say that this is, low quality evidence for these differences, but the one thing that was significant is preeclampsia. And I think there may be a number of reasons for that. So in conclusion, most of the studies on frozen versus fresh transfer have reported benefits of frozen transfer. However, there are some outcomes that may be better in fresh cycles. And the studies on freeze-only transfer are more limited, but most have suggested benefits compared to fresh transfer, although primarily in populations such as the high responders. So clearly we need more studies looking at this, and I think we need to focus on the transfer protocols. There are studies, and I think some preliminary data showing that some of these differences may be related to the corpus luteum. So patients who have no corpus luteum, have one corpus luteum, or have multiple may have very different pregnancy outcomes. And I think as people look into that more, and if we can control for these different transfer protocols, that may help us understand a little bit more why we see these differences. So given advances in vitrification, I think the evidence suggests benefit of freeze-all in some patients. And with the increasing use of PGS, there has been a shift towards freeze-only cycles. Clearly, it is beneficial for the high responders in terms of decreasing the risk of OHSS, but there, are the disadvantages of perhaps increased cost, definitely time, and possible loss of embryos during the freeze and thaw. So these findings are encouraging in the oncofertility population, as frozen transfers are often necessitated for these patients. However, the majority of cryopreservation cycles now for oncofertility are oocyte cryopreservation, and we need a lot more studies in this group. And I think the studies are needed on also frozen embryo transfer in cancer patients versus those with other types of infertility. So I have a number of references, and I'd really like to thank Angie Wang, who is a wonderful third-year resident who is going to be going into reproductive endocrinology, and she helped with some of these slides. So with that, any questions?